Assalamu alaikum, dear all. Good evening to the PSA Karachi online lecture series. I'm Dr. Abdullah, and today we welcome Dr. Kenza Ahsan. Dr. Kenza is an assistant professor in the Department of Anesthesia and Critical Care at Dr. Ruth K.M. Bufao Civil Hospital, Karachi. She has been working there for the last 4 years and has trained from the same institution as well. She's going to present the topic of subarachnoid hemorrhage and its anesthesia concerns. Dr. Kenza has also took an active participation in the PSA online lecture series in the past and has been an integral part in writing management protocols in the ICU handbook second edition in civil hospital. Dr. Kenza, over to you.
Assalamualaikum. Can you hear me all? Hello, can you hear me all? Can someone please confirm if you're hearing me? Abdullah?
Yes, we can hear you. Please carry.
Dr. Kenza, can you hear us? We are having trouble with the voice.
Can you hear me now?
Yes,
Yes,
you're audible to us now.
Okay. Sorry for the inconvenience about the voice. So I was talking about the prognosis of the subarachnoid hemorrhage. Its mortality is very high in low middle income countries. Unfortunately, we have a mortality of about 50 to 70% in low middle income countries as compared to the well equipped and well highly equipped hospitals. Because we have data which I came across during making my presentation. It was the 35%, but it was in a well-equipped setup where hospital access is reachable to the patients. Why this topic is very important for anesthesiologist is because we came across at different phases in resuscitation of these patients, initial resuscitation, which has been done by the anesthesiologist or the critical care physician, and transport of suspected patients to the radiology department, and neuroradiology suits, intraoperative and the postoperative management of such patients, which we deal in our neuro OTs. So this topic is very important, and we need to discuss about it in our further slides. That what is subarachnoid hemorrhage, what are the causes, what is the incidence, and what is the epidemiology, and how we can give a safe anesthesia to such patients. When we talk about the incidence, WHO study has said that it has a tenfold variation in the age-adjusted annual incidence in countries in Europe and Asia, from 2 cases per 100,000 population in China to 22.5 cases per 100,000 patients in Finland. Why there is a wide variation in incidence in China and in other countries? Just because of their dietary habits, their socioeconomical status. But when we talk about the low middle income countries, there's a high incidence of subarachnoid hemorrhages, which result in the neurodegenerative disorders in such patients, and mortality is really very high, as I said earlier. Now, what are the causes of subarachnoid hemorrhage? The most common cause, 70 to 85%, we have the cerebral aneurysm. Second is atriovenous malformation. Third is tumor and trauma or non-aneurysmal perimesencephalic hemorrhages. These are the main cause of the subarachnoid hemorrhage, but we are more detailed, but we more discuss detailed in subarachnoid hemorrhage, cerebral aneurysm. We are going to discuss in detail the cerebral aneurysms, which basically lead to the hemorrhages. Now, what is a cerebral aneurysm? Cerebral aneurysm is a cerebrovascular disorder in which weakness in the wall of the cerebral artery or vein causes a local dilatation or ballooning of the blood vessels, which result in the hemorrhage in subarachnoid space. Now, what are the most common sites of these hemorrhages? As I mentioned in this slide, that anterior communicating artery or the anterior cerebral artery, it is the most common site of the hemorrhage. Second is the anterior internal carotid artery, and third one is the middle cerebral artery. Why the anterior cerebral artery or the anterior communicating artery is most common site for the rupture? Because whenever there is a bifurcation of any artery or any vessel, there is a more chances of rupture or aneurysm breakage. As we have learned in our physics, whenever there is a more resistance, obviously there is a more chances of rupture or the breakage. What are the most common types of aneurysm? Perianeurysm, like in this picture, we have said this is secular aneurysm or the giant fusiform traumatic and myotic aneurysms. Now, when we talk about the etiology, previously it was thought that it is congenital in origin, but now there is research and studies have found that it is primarily acquired. And why acquired? Because when we went to the study, we found that patient with the high blood pressure or patient with the comorbidities have more common persons who have aneurysms and previous history of family history. Ruptures is thought to correspond to the size of the lesion as the wall becomes thinner as the aneurysm enlarges. Lesion almost always occur at the bifurcation of the vessel, which is the site of the maximum hemodynamic stress. As I said earlier, whenever there is a bifurcation, there is always a resistance. So it is the main site of the rupture. Pressure within the aneurysm is at systemic levels, hence rupture occurs, and periods of increased blood pressure may cause this to happen. Now, when we see the incidence between the female to the male ratio, we found that it is more commonly in female population comparative to the male population, where ratio is 2:3, and more males under 40 or more females above 40. And the risk factors, as in any of the comorbidities, we have found that hypertension, smoking, alcohol abuse, and the drug abuse are the most common risk factors for a cerebral aneurysm, which ends up into, unfortunately, in subarachnoid hemorrhages. And there is also family history of subarachnoid hemorrhage, family history, aging process, sedentary lifestyle. These are the mostly the reasons or the risk factors for subarachnoid hemorrhage or the cerebral aneurysm. Now, what are the prevention methods we can take to reduce the risk factors of subarachnoid hemorrhage? Treatment of high blood pressure with antihypertensive medication is recommended to prevent ischemic stroke, intracerebral hemorrhages, cardiac, renal, and other end organ injuries. By the way, these are the guidelines from the AHA, which has recently been updated in 2024. And they have found that risk factors can be prevented if we control the blood pressure. This has a tremendous effect in preventing the subarachnoid hemorrhage. And hypertension should be treated as such treatment may reduce the risk of the subarachnoid hemorrhage. Tobacco use and alcohol misuse should be avoided. This, as I already mentioned, these are the major risk factors for any aneurysm to rupture. Size and location of the aneurysm and the patient's age and health status. This is the newer recommendation for the prevention of the risk factor, according to the AHA, that if you have any family history, first degree member have a history of aneurysm, so his family member should be diagnosed uh, uh, preemptively to prevent the complication of aneurysm rupture. Consumption of a diet that is rich in vegetable also decrease the risk of the subarachnoid hemorrhage, as we seen earlier in the incidence. Why it is low in the Chinese population? Because they have a very rich diet, which is mostly in vegetables or the boiled food. This is usually seen in AHA guidelines. And non-invasive screening of the patient with familial, at least one first-degree relative who has a history of subarachnoid hemorrhage or a history of subarachnoid hemorrhage to evaluate the aneurysm. After an aneurysm repair, immediate cerebrovascular imaging recommended to identify remnants or recurrence of the aneurysm that may require treatment. This is the latest recommendation by AHA, that if the aneurysm has been treated by clipping or by surgically clamping of the aneurysm, it doesn't mean that patient has been prevented for further aneurysm breakage or rupture or the hemorrhage. These patient has to be on follow-up like every 3 months, 6 months, depending upon their site of the location and disease progress. So these patients need to be evaluated further uh, through their through their clinics or by their neurosurgeons to prevent the further hemorrhage. Now, what are the sign and symptoms patient comes to you with subarachnoid hemorrhage? Patient, the most commonly sign and symptoms is a severe headache. Usually patients say that we didn't have such headache in our lifetime, the thunderclap headache. Along with the headache, patient may also complain the loss of consciousness, neck stiffness, photophobia, and vomiting. These are the commonly sign and symptoms if a patient coming with the cerebral aneurysm or the subarachnoid hemorrhage. Now we are going to discuss how can we classify these patients and how can we go towards our diagnosis that whether our patient is uh, prognosis, how can we diagnose the prognosis of such patients. So we have three classification system. Number one is the Hunt and Hunt's classification. Second is the World Federation of Neurological Surgeons. Third is the Fisher classification, which is based on the CT scan findings. Now, these two, I have compared the two classification. Number one is the Hunt and Huss classification, and second is the World Federation of Neurological Surgeons, in which the grade 0, if the aneurysm is unruptured, and the grade 1, patient coming with asymptomatic or minimal headache and slight knuckle rigidity, and the grade 1 for the World Federation, it has a Glasgow Coma scale of 15 with no motor deficit. In grade 2, we have moderate to severe headache, knuckle rigidity, but no neurological deficit other than the cranial nerve palsy. And on the other scoring system, if the GCS of 13 or 14 with no motor deficit. By the way, patients coming with the grading of 1 and 2 have a good prognosis if they come early to the neurological setups and diagnosed early on CT scan or on these clinical findings, they have a good prognosis. But with the patient with the grading of 3 to 5, like I've mentioned, if the Hunt and Hunt's classification according to 3 grading, if a patient is coming with a drowsiness, confusion, or mild focal deficit with a GCS of 13 or 14 and with motor deficit, it has the we have a doubt about the prognosis of such patients. Now, grade 4, we have if patient is coming with stupor, mild or severe hemiparesis, possible early decervitate injury, rigidity, vegetative disturbances with the GCS of 7 to 12, with or without motor deficit, these fall into the grade 4 classification, and grade 5 is a very severe condition in which patient comes up with a deep coma, decelerated rigidity, bound appearance, and the GCS of 3 to 6 with or without motor deficit. Unfortunately, these patients usually do not have a good prognosis. They may end up in ICU, and we cannot say that they have a mortality of more than 50%. Now, if we talk about how can we diagnose these patients on CT scan, and the grading system would be, it is called as a Fisher grading of aneurysm, subarachnoid hemorrhage. If we found blood, that if no blood is found, that is a grade 1. If a diffuse thin layer of less than 1 millimeter, then it's a grade 2. And if a localized clot or thick layer of subarachnoid blood, which the diameter of obviously layer of greater than 1 millimeter, then it's a grade 3. And with the intercerebral interventricular bleed with diffuse or no subarachnoid blood, then it's a grade 4 grading of Fisher grading. This is the comparison between the two CT scan of the patient. On the extreme right, you can see the normal CT scan of a patient with the normal isodense signals, that is a dark gray, the CSF in the subarachnoid space. And on the left side of the picture, there's a hyperdense signal, that is a light gray in the subarachnoid space, that is due to the presence of the blood. So how can we diagnose these patients on clinical grounds? Like I said, the patient came up with a saying that I have a severe headache or episodes of unconsciousness. And also we can diagnose these patients on CT scan, MRI. And if you do not get any diagnosis on CT scan, then we have another option of the cerebral angiography. No, it's a brief recommendation recently about by the AHA that subarachnoid hemorrhage is a medical emergency. A high level of suspicion for subarachnoid hemorrhage should exist in patient with acute onset of severe headache. Head CT, if non-diagnosis, should be followed by the lumbar puncture. And if aneurysm is detected on CT and you cannot diagnose the position, location of the diagnosis, then the digital subtraction angiography is recommended, which is a recent update in the literature. MRI may be reasonable for the diagnosis of subarachnoid hemorrhage with patients if the non-diagnostic CT, if someone couldn't find, if a patient come later on, then MRI obviously is a diagnostic feature. And DSA, like I said, digital angiography, dimensional rotational angiography is indicated for detection of aneurysm in patient with aneurysm and planning for the treatment option in such patient. Then this technique, that is DSA, is more efficient in diagnosing the patients. Now, what are the treatment of such patients? The goal is to prevent the cerebral vasospasm and rebleeding, which is the most common complication of subarachnoid hemorrhage. If a patient is coming up with a subarachnoid hemorrhage with low GCS, then what are the further later on complication of these patients are mostly the vasospasm, rebleeding, and the hemodynamic changes. So we have to treat these, we have to treat the complications, and also we have to do the general precautions of such patients like bed rest, pharmacological interventions if needed, anticonvulsant if a patient is coming up with the history of seizure activity, antihypertensive to control the MAP, analgesics, sedatives, laxatives, and in case of vasospasm, which I'll discuss later on in my slides, that we have to consider the triple H therapy, that is hypervolemia, hypertension, hemodilution, calcium channel blocker, and obviously surgical intervention is the definite treatment of subarachnoid hemorrhage, which has to be done as early as possible. Should not wait for 12 hours, 6 hours, or after vasospasm to resolve. No surgical intervention at any level of the grading if a patient is coming with a grade 1 or 2, or if patient coming with grade 3 or grade 4 classification, either the Hunt and Huss, either the World Federation of Neurological Scale or the Fisher scale, surgical intervention is the definitive choice of treatment for such patients. Now, what is the surgical treatment of such patient? We call it the occlusion therapy. It's either surgically clipping by doing the craniotomy or using the radiological endovascular technique with detachable coils. Basically, surgical intervention can be done by the two methods. One in the endovascular suit, which is obviously by interventional radiologist, and surgically by a neurosurgeon with an open craniotomy, which helps in the early occlusion, and it prevents the rebleeding and evacuation of the subarachnoid blood. While doing the clipping may also reduce the incidence of vasospasm. Early clipping or coiling within 72 hours is now the goal for all grades of subarachnoid hemorrhages, replacing the outdated approach of delayed aneurysm occlusion until after the period of vasospasm for poor grade subarachnoid hemorrhage. It was previously said that you can wait and this vasospasm to resolve and do the surgery. But now the newer recommendation, according to the AHA, is that as early as possible, it has to be done to prevent the further damage, which we'll discuss later on. Uh, um, uh, uh, Prevent further complication of this disease. Now, as I said, what are the indication for endovascular and surgical clipping? Endovascular coiling we should consider in the patient with who those are elderly with multiple comorbidities, in which the surgical intervention would be most hazardous to those patients with obviously hemodynamic instability. This obviously the endovascular coiling will be the choice of treatment in such patients. Patient having internal carotid aneurysm or the posterior circulation aneurysm or the basilar tip aneurysm, and surgical clipping should be considered in young middle cerebral artery aneurysm, fusiform or aneurysm with a wide neck, and aneurysm at the bifurcation or end, ruptured subarachnoid hemorrhages. Surgical clipping is the choice of treatment. Now, in endovascular coiling, it's an angiographic coiling of aneurysm done under general anesthesia. Extremely coiled material is placed inside the aneurysm in variable amounts till it's uh, full of them, and aim is for the aneurysm to thrombose and new intima to grow over the inlet. Now, what will be the choice of anesthesia while doing the endovascular? That is, it has been discussed in multiple researches that general anesthesia is more preferable compared to the regional anesthesia in such cases. And now the surgical clipping while doing the craniotomy, we just clip the ruptured aneurysm, and it will be done by doing the clipping method. Now, I'll discuss further on what will be the pre-operative, intraoperative management in such patients. Obviously, if a patient is coming with these patients, that pre-operative assessment should be done in recovery or immediately whenever this patient is coming in emergency suits. Blood pressure is important to maintain that. PP should be maintained at a safer level, that there should not be any hypo or hypertension. Fluid status, that is, if overloaded, may lead to the congestive cardiac failure, pulmonary edema, or if dry, may cause the vasospasm. If hyponatremia is present, may cause the cerebral edema. Now, I don't know if all of you have known or not, the cerebral salt wasting syndrome is basically secondary to this subarachnoid hemorrhage. So we need to consider, we need to know the proper cardiovascular stability of such patients, and we have to manage throughout the perioperative period. If we talk about the respiratory, prolonged bed rest may lead to the atelectasis in such patients and pneumonia. So preoperative assessment of the respiratory system is very important. And CNS examination is really very important. If a patient is coming with the low GCS, so you have to see the pupillary size, aphasia, gross motor weakness, you have to mention in the preoperative assessment that these findings you have seen in such patients. So you can compare the post-op outcome or post-op deficit due to the complication of a subarachnoid hemorrhage. You should be knowing that these were the preoperatively weaknesses or the motor deficits of such patients. In general, as for any preoperative examinations you do in patients. It's a routine function, CBC, electrolytes, renal function, blood sugars, coagulation provided should be done priorly, ECG, chest X-ray, and echo if patient with questionable cardiac functions. If you have time, you should do these tests on priority. Now, As any of surgical procedure in neuroanesthesia, our aim is to give a neuroprotective anesthesia in such patients, and we have to relieve the anxiety of the patient because it will cause the major fluctuation of the blood pressure, and pre-medication for adequate assessment of is avoided in such patients to obviously to assess the neurological status of these patients, and titrated dose of sedatives should be used to relieve the anxiety and to prevent the respiratory depression, as hypercapnia will increase in cerebral blood flow, further increasing the ICV. By the way, in all neurosurgical patients, we have to maintain the cerebral perfusion pressure, which is, I'm sure you must all be knowing that it's MAP minus ICP. So you have to uh, maintain the MAP, as well as you, obviously, we do not want to increase the ICP. So our major goal would be to maintaining the MAP between 65 to 60, and we should and would not want to increase the ICP by any of the mechanism which can increase the ICP, like by doing the hypercapnia, hypoxia. These conditions should be prevented intraoperatively, and also to prevent the secondary brain injuries. Now, what are the monitoring as ASA1 monitoring? Along with the ASA1 monitoring, you should be having the ECG and arterial line pre-operatively, not intraoperatively, before giving anesthesia to such patient. If a patient is having aneurysm, then CV, arterial line should be passed pre-operatively before putting patient under anesthesia. Respiratory monitors, obviously, saturation and tidal CO2 and neuromuscular monitoring should be done. Now, when we talk about the CNS monitoring, then EEG, BIS, ICP monitoring, and evoked potential if available. But now the latest recommendation, according to AHA, it is not as mandatory that you should be having the somatosensory evoked potential or motor evoked potential intraoperatively. But if you have this facility available in your setup, it will give you an extra benefit to prevent the so that you can early detect the cerebral ischemia, and you can manage intraoperatively by maintaining the fluid, by giving obviously by maintaining the map of the patient. And most important, the urine output is very important in such patients, because the complication we are dealing with, if patient is having vasospasm and we're giving the triple H therapies, we need to see each and every organ to prevent the complications. Now, what will be the principal induction agent in neuroanesthesia? I'm sure that you've coming across multiple lectures. Thiopentol is the drug of choice in neuro surgeries, and obviously the propofol with a dose of 1.5 to 2.5 milligram per kg. Mild hyperventilation may be instituted in patients with elevated ICP, but it's controversial. Like previously, it was said that hyperventilation should be followed, but now it has been recommended that it should not be more than, it should be in a limit, in a range, like it should be between 28 and 35 millimeter of mercury of PCO2. You should not hyperventilate the patient, because it will further deteriorate the patient by increasing the I by decreasing the blood flow in such patients. Mild hyperventilation. Dexamethasone is often used for the muscle relaxation for intubation, clinically safe, although theoretically increases the ICP, but if you are using it with thiopentanol or propofol, and in emergency situation, this dexamethasone has a tremendous effect. While rocuronium is obviously the drug of choice, and complete muscle relaxation should be ensured while using the laryngoscopy or any point. You should take time, you should take the muscle relaxation to work before doing any laryngoscopy. Why? Because we want to avoid any hemodynamic instability at every point from induction till the time of the clipping. If I'm talking about the aneurysm repair, if the patient is coming with the aneurysm, because our target would be that we do not want to harm the patient by giving the hemodynamic instability and MAP increases, and God forbid the rupture of the aneurysm may occur, and we come up into a disastrous situation. So our anesthesia should be balanced. It should be more more balanced, and it should not increases the transmural pressure of the artery or the vein which is going to be clipped or which is going to be coiled. Now the laryngoscopy and what will the intubation technique, the prophylaxis against the rise in the blood pressure may be given in the form of the high doses of beta blocker like short-acting remifentanil or the beta-adrenergic agonist, labetalol, esmolol, topical or intravenous lignocaine with high MAC isoflurane or sevoflurane. You can give, or you can give the thiopentranol while doing the laryngoscopy. Now, what is the purpose of doing this? Is just to attenuate the effects of laryngoscopy and intubation, because slight variation in hemodynamics or blood pressure can impair the cerebral perfusion pressure of such patients, which may increase, obviously, like I said earlier, the cerebral perforation pressure is equals to the MAP minus ICP. So we do not want to increase the MAP, which result into hazardous effects. And remifentanil can be used to avoid the variation in the hemodynamics if available at your setup, or fentanyl. Deep inhalation anesthetics may be used in good subarachnoid hemorrhage gradients, but avoided in those with elevated ICP. Sevoflurane is a preferred drug. Laryngoscopy intubation should be smooth. As I said, everything should be smooth. And now, what are the maintenance should be done with the propofol infusion or the remifentanil inhalation agents, or the intravenous agents can be used for the maintenance. And blood pressure should be kept within 20 millimeter of mercury below the patient's baseline. Why below the patient baseline? If a procedure is, if clipping is going to be done openly, open craniotomy, then sometimes surgeon may ask you to please decrease the blood pressure. So he want to clip the main vessel. So that at that time, but not more, but you won't compromise the map of these patients. And prior beta blocker is preferred to avoid the reflex tachycardia due to the induced hypotension and rebound hypotension after discontinuation of the hypotensive agents. Now, what is the role of the mannitol? It has to be given, not preferably, but if required, when there's, if surgeon is saying that he's saying that if you see that ICP is going to raise, then you can give the mannitol at 1.5 gram per kg, but it should be given slowly, not fast, because it has a very deleterious side effects. With the furosemide of 0.3 mg per kg is given to shrink the brain and provide good operating condition. It takes about an hour for mannitol to be maximally effective, so it should be started as soon after BP has settled down from intubation. Okay. Now, hypertension induced at the time of dissection and clipping with MAP reduced to about 65 as aneurysm is being approached, and 50 with clipping. Agents of choice are nitroglycerin, sodium nitroprusside with prior beta blockade. Now their time is very important. That it has to be before giving the before inserting a clip, 5 minutes of clipping, and after 5 minutes, total 10 minutes time is an ideal time to prevent the cerebral ischemia. If hypotension, if the surgeon is asking for asking for hypotension to clamp the aneurysm, or the if God forbid the bleeding has occurred. But you should also prevent the cerebral ischemia. Minimal time should be asked by the surgeon, and you should maintain the map. The target is to maintain the map. It should not be less than 60 to 65 millimeter of mercury. Now, what are the critical points where hemodynamic changes can be seen? Like securing of the head with Mayfield pins, skin incision, and periosteal flap elevation. These are the more critical situations, so you have to be very careful. And you can give propofol in low doses, or narcotics like remifentanil in low doses, which can safely prevent these stimuli. Now, the anesthetic management during surgical and endovascular treatment, these are the recommendations which I found in literature, that minimization of the degree and duration, like I earlier said, the duration should be very minimal, not more than 10 minutes. If it's more than 20, then obviously chances of cerebral ischemia will be high. And there are insufficient data on pharmacological strategies and induced hypertension during temporary vasal occlusion to make specific recommendation. And induced hypothermia during aneurysm surgery is not routinely recommended. That you should not ask for the hypothermia for aneurysm surgery. And intraoperative hyperglycemia should be avoided. And like I said earlier, and general anesthesia is preferred choice for the endovascular procedures. And uh, there have been no studies comparing these two techniques. One of the main goals of the anesthetic techniques is to keep the patient motionless to optimize the quality of the images used to perform the endovascular procedures. Hence, general anesthesia with the endotracheal intubation is often preferred for these procedures like endovascular coiling. Now, the endovascular procedures differ from the open procedure in that the anticoagulation with heparin is frequently administered during the embolization of the aneurysm. Patients who have undergone anticoagulation required rapid reversal with protamine if intraprocedural aneurysm rupture occurs. Now, don't confuse with the clipping with the endovascular coiling. This I'm talking about the endovascular coiling. During endovascular coiling, because they are giving, these patients are giving frequent administration of the heparin. If at any time there is a intraprocedural aneurysm rupture and you have to resuscitate the patient, then you can give the protamine intraoperatively, and you can also think of anti-platelet activity, but its use is obviously controversial. Now, if the intraprocedural aneurysm rupture occur, now what it will associated with sudden rise in transmembrane pressure gradient increase. Obviously, increased MAP or decreased ICP. Like I said, any change in these parameters may end up into the disasters. The chance of occluding will be better than dura is open. Why? If it occurs at the time of intubation or at the point when the position is going to made for neuroanesthesia, then it's very difficult to manage this case. But if the dura is open, then obviously surgeon can easily clamp the proximal and the distal vessels, and the chances of mortality will be obviously low. But it can lead to the massive blood loss and higher mortality. So preferred acute management is the temporary occlusion of the arteries proximal and distal to the bleeding, which allows the surgical access, and blood pressure should be maintained and blood loss should be replaced. And at that point, decrease in MAP may be required to facilitate the orientation and clipping. But this will compromise the cerebral perfusion and should be used at last resort technique. This has to be more focused. That time is very important in such patients. If the surgeon could not secure the bleeding and time of clipping is getting higher, more than 10, 15, 20 minutes, then the chances of cerebral ischemia is more. But the decreasing MAP should be the last resort. Okay. Now, the reversal is these patients should not be reversed on table. These patients should be transferred to this critical care unit where everything has to be assessed, and people should be controlled with the short acting pharmacological agents like propofol or the narcotics infusion. And further agents to reduce the BP might be used if infusions are found unsafe. Remifentanil and fentanyl are the ideal choice because it patient because we can assess the neurological status afterwards of these short-acting sedatives. If we have the high dependency unit or or intensive care, then we should transfer these patients to the ICU to assess the neurological function post-operatively. If emergency is unexpected, delayed, or there is a new neurological deficit, then CT or angiography is indicated post-operatively. And the patient with the World Federation Neurological Scoring Scale of 3 to 5 or with perioperative complication should not be extubated after the procedure and will require the management in ICU. Now, the post-operative management, we have to assess major new neurological signs like vasospasm, rebleeds, infarction, post-op fluid status. These are the major complications after the subarachnoid hemorrhage. And I'm quickly, as we are short of time, I'm going to quickly discuss a few of them. Now, major complications like hydrocephalus, intraventricular hemorrhage, intracerebral hemorrhage, increased ICP, cerebral vasospasm, seizures, fluid and electrolyte imbalance. This we usually come across in post-operative period. So we have to manage these patients in ICUs. Like if we talk about the prevention of cerebral ischemia of cerebral vasospasm usually occur 3 to 12 days post-operative of subarachnoid hemorrhage and lasting approximately 2 weeks. Now, what is the prophylaxis for vasospasm? Like I said earlier, it its treatment is the triple H therapy. We'll give oral nimodipine, positive fluid balance, and prevention of the hyponatremia. And symptomatic treatment consists of the triple H therapy. Now, what is the nimodipine? Nimodipine is a calcium channel blocker, and it has to be given all patients 60 milligram every 4 hourly and should be continued for 21 days. Now, why 21 days? As we said, there's chances of cerebral ischemia is more in next 2 weeks. So it has to be continued for the next 21 days. Now, what is a triple H therapy? Triple H therapy refers to the hypertension, hypervolemia, and hemodilution. It is based on the concept that the cerebral blood flow will become pressure dependent once autoregulation is impaired. Therefore, an increase in the blood pressure and decrease in the blood viscosity may reverse the vasospasm. The goal is to achieve a systolic blood pressure of 120 to 150 in untreated aneurysm in 200 millimeter of mercury in aneurysm that have been cleft or coiled using hypervolemia with vasoactive drugs where necessary. But mind you, this triple H therapy should not be given to all patients. We have to assess the risk versus benefit of that particular patient. If a patient is having comorbidities and he's having complication, like if he's having the congestive cardiac failure, then obviously we will not consider this option in such patients. So we have to assess our treatment patient to patient. If the chances of if it's a diagnosed vasospasm and patient is having no such hemodynamic instability, then obviously we'll do this therapy in such patient. But if a patient is having history of congestive cardiac failure, history of cabbage previously or stenting previously, then obviously our choice of treatment would be different. We will not be considering of giving more fluid to such patient, but our treatment should be judicious fluid, judicious management, and neuroprotective management in such patients. Okay. Now, the balloon angioplasty is indicated for patient with the deteriorating neurological function. By the way, this is the complication of the vasospasm. Now, what are the systemic complications of subarachnoid hemorrhage? Like I said, the cardiac dysfunction, because it triggers the sympathetic nervous system with the excessive increase in the release of the catecholamines and cardiac dysfunction. This is a manifestation of the systemic and the pulmonary hypertension, cardiac arrhythmias, myocardial infarction, and neurological pulmonary edema. These are the complications of the subarachnoid hemorrhage due to the release of the excess release of the catecholamine. So we have to manage these patients accordingly by preventing these side effects by addressing individually of these complications. Now, what is the electrolyte derangement? Like I said earlier, the cerebral salt wasting syndrome is a complication of this subarachnoid hemorrhage. Why? Because of the excess release of the BNPs and the syndrome of inappropriate antidiuretic hormone. These are the electrolyte derangement in subarachnoid hemorrhages. Most common is the hyponatremia, but you have to diagnose properly. Either it's a cerebral salt wasting syndrome or it's a SIADS, because the treatment is totally 180% degree change. If it's a syndrome of SIADH, obviously then our choice of treatment will be to restrict the fluids. And if it's a cerebral salt wasting syndrome, then obviously our treatment choice would be different. We'll be giving more fluid, we'll be giving sodium concentrated fluids in such patients, but you have to differentiate between the two while managing this patient in ICUs. Now, the rebleed chances is a major complication after the subarachnoid hemorrhage in the first 2 to 12 hours, with reported rates of occurrence between 4 and 13% in 24 hours. Now, what are the factors associated with rebleeding? If a patient is history of longer time of aneurysm, worse neurological statements, or initial loss of consciousness, or previous sentinel headaches, like if a patient is giving history of headache of more than 1 hour, okay, and large an aneurysm size and systolic blood pressure greater than 160 post-operatively. So here we have to manage the blood pressure also. So these are the main risk factors for the rebleeding after subarachnoid hemorrhage or the treatment of the aneurysm. Uh, Management of this hydrocephalus is Even you can put a EVD, endoventricular drain, or lumbar drainage, depending upon the clinical scenario. It is not recommended that you should put EVD in each and every patient. It is a revised recommendation from the previous guideline. And subarachnoid hemorrhage associated with chronic symptomatic hydrocephalus should be treated with a permanent cerebrospinal fluid diversion. If patient is having a history of raised ICP previously, chronic symptomatic with the raised ICP sign, then obviously you will think of putting a cerebrospinal drainage EVD in such patients. And weaning should be done after 24 hours if no neurological signs. But routine fenestration of the terminalis is not useful for reducing the rate of shunt-dependent hydrocephalus, and therefore should not be routinely performed. What are the management of seizures associated with the subarachnoid hemorrhage postoperatively? There's the use of the prophylactic anticonvulsant. Patient should be loaded with the phenytoin or other anticonvulsant medicine in the immediate post-hemorrhagic period. And the routine long-term use of anticonvulsant is not recommended, but may be considered in patient with the known risk factors for delayed seizures disorders such as the prior history, intracerebral hematoma, or intracerebral hypertension, infarction, or aneurysm. Like previously, it was said that patient should be on anticonvulsant medication for a longer duration of time. But recent recommendation is that not each and every patient should be put on the long-term anticonvulsant. But if the patient having such risk factor, then we can think of putting this patient. But on a shorter duration, you can put patient on the anticonvulsants. Now, what are the management of the medical complication, administration of the large volume of hypertonic fluid and intravascular volume contraction is not recommended after subarachnoid hemorrhage. Monitoring, but you should not confuse this point with the vasospasm treatment. That is for the vasospasm treatment. But after every subarachnoid hemorrhage, you should give the judicious fluid, not giving excess fluid, not giving excess intravascular volume. You have to assess each and every patient accordingly. Monitoring volume status is very important post-operatively. That is why CBC or pulmonary wedge pressure or IVC, ultrasound guided IVC should be measured routinely throughout in the ICUs. And aggressive control of fever should be done to prevent the hyperthermia. Obviously, and standard advanced temperature modulating system is reasonable in the acute phase of subarachnoid hemorrhage, and care for glucose management with strict avoidance hypoglycemia may be considered as a part of the general critical care patients. EKG. Next is the use of the packed red blood cells transfusion to treat anemia is reasonable with subarachnoid hemorrhage who are at risk of cerebral ischemia. And the optimal hemoglobin goal is to it's still to be determined. This is a newer recommendation. It is variable patient to patient. And use of the fluorocortisone acetate and hypertonic saline is reasonable for preventing and correcting the hyponatremia. And heparin-induced thrombocytopenia and deep venous thrombosis are relatively frequent complications after subarachnoid hemorrhage. So early identification and targeted treatment should be recommended in these patients. Now, one more thing that I came across during my presentation, that the use of steroids in such patients. Now, the new recommendation have said that the role of steroid in subarachnoid hemorrhage is controversial. Some studies say that you can use the steroids in such patients, but it is not generally speaking that you should use, because it can decrease the ICP, but it has further complication of increasing glucose level, increased chances of infection. So it's better if you do not use. So it has no beneficial effect of using these patients. So here I end my presentation. Any questions?
Thank you, Dr. Kenza. The session is open for everyone to have your questions entertained. There is one question in the chat box. Dr. Adnan wishes to ask what's the difference between SIADH and cerebral spore wasting syndrome, the diagnostic
Sorry,
differences to consider.
can you, Abdullah, can you please question, please? Hello, can you please Repeat your question, please.
Assalamu alaikum. Madam, the question is in the chat box. It is about the cerebral
Dr.
solid wasting
Dr. Kenza,
syndrome
the
and
question was uh, the diagnostic differences between cerebral wasting syndrome and syndrome of inadequate ADH secretion. The diagnostic differences.
I said earlier, these are the ANPs and BNPs levels should be measured, and obviously in SIADH we usually send the urine sodium, and obviously this serum levels of sodium. We have to compare both, and we have to measure the BNP levels. These are the major diagnostic differences between. You should measure the osmolarity, urine osmolarity, and obviously the serum osmolarity, through which we can compare the differentiate between the two. As I said, in syndrome of inappropriate ADH, there is hyponatremia, but this is not because of the decreased sodium. It is because of the hypervolemia, because kidneys are not making enough urine. But in cerebral salt wasting syndrome, there is BNPs which act on the renal tubules, and they do not your sodium resorption is impaired, and sodium is coming out of kidneys, and obviously urine is also making. So that is the difference between it is actual hyponatremia in cerebral salt wasting too, but in SIDH it is not an actual hyponatremia, it is hypervolemia. These are the types of the hyponatremia. In electrolytes, I'm sure most of you have gone through the hypervolemic hyponatremia, normovolemic hyponatremia, and hypovolemic hyponatremia. These are the types of, these are the two major differentiation can be done by urinary sodium osmolarity. These are the major differences. Hope I'm clear with the question.
Thank you, Dr. Kinza. The floor is still open for anybody to ask the question regarding the topic. Well, with this, I would like to invite Dr. Leena Ayub from Lahore. She has been a regular attendee of our lecture series, and I would like to have her for the concluding remarks regarding this topic. Dr. Leena, please.
Thank you very much. It was very nicely presented, and every aspect was very well in a very small time, which could be done possibly. Congratulations to the worthy speaker. And I think every aspect which could be done in this time was covered. Congratulations to all of you.
Thank you.
Thank you, Dr. Leena, and thank you, Dr. Kenza. With this, we would like to conclude our session. The feedback form is in the chat box for the participants to fill to receive the e-certificates in their mailbox. Thank you very much.